Hello, I'm Brian Donnelly with Northwell Health. March is National Colorectal Cancer Awareness Month, and as part of our commitment to community health, we're here today to talk about the importance of prevention and early detection of colon and rectal cancers, as well as the troubling rise in cases in adults younger than 50. Gastroenterologists are on the front line of this effort, and today we're speaking with two leading experts in the field. First, we have Dr. Christopher Martin, a leading gastroenterologist and president of the medical staff at Northwell's Phelps Hospital. Dr. Martin, thank you for being here.
Thanks for having me.
Also with us is Dr. Peter Stein, director of endoscopy for Northwell in Westchester. Dr. Stein, welcome.
Thank you for having me.
To start, Dr. Martin, very simply, how common is colon cancer?
Well, it's very common. It's the third most common cancer in men and women, and it affects we make about 150,000 diagnoses annually in the United States. About 1 in 25 people get it in their lifetime, so it is the reason why we screen for it so aggressively.
And I say colon cancer, but of course, this month we're talking about colorectal cancer. So in terms of rectal cancers as well, what's the prevalence? And, maybe Dr. Stein, you can speak to that.
When we're talking about colorectal cancer, we don't separate the two when we're talking about broad data. So when we say one, we say all in terms of colorectal cancer. So when we talk about colon cancer being the third most common cancer in the United States, we really mean colorectal cancer, and those are lumped into the same basket when we're talking about those statistics. But really the take-home point in terms of colon cancer is that this is a very prevalent disease. This is something that we can screen for. We can screen for at appropriate ages and intervals, and it's preventable.
And we hear so much now about younger people getting colorectal cancer. Can you talk to that a bit? What are the stats and what should people know?
Yeah, we don't exactly know why this is happening. It probably has something to do with environment, diet, lifestyle that it probably affects a lot of different things. But we've seen basically a near doubling in the number of colorectal cancers that we diagnose in under 50 over the last 20 years or so. So whatever the reason is, we're seeing a lot, and so that's why they did bump the screening guidelines age down from 50 to 45 for everyone, men and women.
And so that was a factor in that decision to lower the screening age from 50 to 45.
Absolutely.
Wow. And that's a staggering statistic, doubling in prevalence.
Mm-hmm.
Yes, we had robust data that came out several years ago. This was more than 5 or 6 years ago. There were large studies coming out that showed that the prevalence of colon cancer, rather colorectal cancer, in patients younger than the age of 50 was increasingly rising. We know that we do a good job with screening patients who are older than 50. However, patients in those younger age ranges, the incidence of colorectal cancer has been steadily rising. Really, the question is why we don't know, as Dr. Martin just mentioned. Over relatively short periods of time, and by that I mean decades, it's not as if our genes have dramatically changed, so it has to be something environmental. There's multiple hypotheses for what that could be, but we really don't know why the incidence has increased.
Yeah. So, with all that in mind, what should people be looking for who, may be in this age range and concerned about this?
For the average risk patient, that means for a patient who does not have a predisposing diagnosis or condition, such as a genetic abnormality that was previously identified, a history of ulcerative colitis or Crohn's disease, or what have you. So for the average risk patient who does not have a strong family history of colon cancer, who's younger than age 45, if that patient develops a change in their bowel habits that's very much outside of the norm for them, meaning persistent diarrhea or constipation, a change in the caliber of their stool, meaning that it suddenly becomes very narrow, for instance, when it wasn't in the past, rectal bleeding, if they notice a sudden change in weight or significant abdominal pain, or if they go to the doctor and they're found to be anemic, those would all be alarm signs or symptoms that would then lead us to consider sending that patient for a colonoscopy and a further evaluation.
When talking about screening age for those with a family history, is it different for them?
Yeah, it would be 10 years before the diagnosis age of the first-degree relative, which is generally a parent or a sibling. So that they certainly get screened earlier. But the most important thing is that it is something that we can screen for. It's something we can prevent from happening in the first place. So if you have a family history, it's one of the better ones to have because you can actually avoid getting it because you take out a polyp in the pre-cancerous phase during a colonoscopy, so you never get the cancer. That's why we screen people.
Yeah, no, it's such a fortunate thing because there are cancers where there are not screenings available. And so here we actually do have something that people can do proactively, following the proper guidelines. A lot of people, have questions about, what you can do, right, to prevent. And so does diet and lifestyle affect risk? And if so, what preventative steps can individuals take? Dr. Mard, maybe we can throw that to you.
Sure. I mean, the good news is that there's some overlap with this and some other things that people would recommend for things like cardiovascular health. So not very strong associations, but certainly we see a sedentary lifestyle being a risk factor, low fiber diet being a risk factor. There's some data for red meat, charred meat, but you can be a marathon runner who is a vegan, and you can still have colon polyps and colon cancer, and it's an asymptomatic condition when it starts. So it's really important just to get screened, even if you're having, the ideal diet and lifestyle.
And, we've heard a lot in recent studies about this rising incidence among younger people to do with ultra-processed foods. What can you tell us about that? What is an ultra-processed food, and what should people know about it in relation to colorectal cancer?
Sure. So this goes back to the same thing that Dr. Martin was just mentioning. You can really boil this down to something that's very simple. You can consider food as anything that your grandparents would have identified as food, as something that they would have put on the dinner table. And if it's coming out of a package or a can and it looks like it was made in a factory and doesn't look like something that came out of the ground or a farm, then you can probably consider that ultra processed. There are various recommendations and influencers and whatnot who have a lot of different recommendations in terms of diet nowadays. My general recommendation is very simple. Eat food. If you look at the packaging and it has more than 5 ingredients, then it probably has too many. If it has ingredients where you don't understand or recognize the ingredients, then it's probably ultra-processed. And so you can keep it very simple in terms of those kind of general parameters.
So, Dr. Martin, many people understandably say, I feel fine. Do I still need screening? What's your response to that?
Well, it is something that we hear a lot, but, unfortunately, the folks who get colon cancer eventually become symptomatic, and they get stuck in a situation where there's a lot more treatment that involves morbidity and mortality, and that you had take something where you could have a simple procedure which prevents a cancer in someone who's asymptomatic, or you wait until it's symptomatic, in which case you then need a surgery and probably chemotherapy at that point, if it's even curable, okay? And found early, it is definitely curable and preventable.
And that's great news, Dr. Stein, please, yeah.
If I could add to that, and I speak with patients about this very frequently, you can think of colonoscopies as colon cancer prevention. So we really use the wrong terminology around a lot of the processes that we go through. We say colon cancer screening when we're performing colonoscopies for average risk patients that are within the screening guidelines. We're really not screening for or specifically looking for colon cancer the majority of the time. Yes, of course, if someone has colon cancer, we should find that the vast majority of the time. But the real point of performing colonoscopies is not to screen for or find cancer, it's really to prevent cancer. So very frequently when I'm speaking with patients in the clinic, that's the take-home message. This is a preventative test, and that's because we can both diagnose and treat during the colonoscopy, meaning we can find polyps which have the potential to turn into cancer and remove them immediately during the procedure.
I mean, I feel like that's a really important point. Is that common? That, when you're there, you're able to, I don't know if the term is remove, resect a polyp?
Yeah, at least a third of the colonoscopies that we do, we find polyps that are pre-cancerous. So that's an opportunity right there to prevent a colon cancer that would have developed down the road. And it's an advantage of colonoscopy over other screening tests. And we can get into that, but basically there are non-invasive methods, absolutely, that some stool tests, for example, Cologuard namely, and some other new ones, have excellent sensitivity for colon cancer. But at that point, you need treatment for colon cancer. Their sensitivity for precancerous phase is still not even half of them. Half of the precancerous polyps will be picked up. So you're, again, missing the opportunity. Hopefully we'll have a day someday where we do have a non-invasive test that really kind of triages the folks who have polyps. You get a colonoscopy, everyone else sit tight and come back for your non-invasive test. But it'll happen in our screening lifetime. It's just not there yet.
Right. And I feel like most people know what a colonoscopy is, mostly for the fear of it. But Cologuard, you mentioned that. Can you explain what Cologuard is, and I guess in relation to colonoscopy, what are the differences, advantages, disadvantages?
Yeah, I mean the advantage is that it's easy to do. You deposit a stool specimen into a container that comes to your house and you mail it away. But and it has about 94% sensitivity for cancer, whereas more like 43% sensitivity for large polyps. So that's a significant downside of it. It's better than nothing, absolutely. So yeah, that we should definitely advocate for any type of screening at all. But if you want to be as preventive as possible, colonoscopy is the best appropriate test.
For people that are worried about getting a colonoscopy, I feel like embarrassment is often in the realm of the concerns. Dr. Stein, can you speak to that? And what would you say to help somebody get through that concern?
Sure. Most patients who are apprehensive about the colonoscopy are apprehensive about one specific aspect of the colonoscopy. Or they're concerned about missing a day of work, or they have difficulty with getting a ride to the colonoscopy. So there's always one component which is the sticking point. In terms of the personal apprehension, if you set aside the employment part or the ride, people tend to be concerned about the prep the day before, which is much easier than it used to be. 10, 15, 20 years ago, patients needed to drink a bowel prep, which was typically around 2 gallons. Wow. The current preps, which are common, are much, much easier than that, much lower volume. So the entire process has gotten easier. Typically, the prep that I use, the actual medication that patients have to drink, is around 1 liter, and we split that into 2 halves. So each half you have to drink is maybe 2.5 cups. So you're not sitting there looking at a 2-gallon or 1-gallon jug that you have to get down. The rest of the process has just gotten much more humane, although one could argue there's no humane way to prep the colon because that's human anatomy. But still, it's gotten really as easy as it can get. Many people still are just apprehensive about the idea of the procedure in general. My argument with that is that this is something that we do every day. The anesthesia is incredibly safe. Typically in New York State, it's standard of care for an anesthesiologist to be present, or a CRNA, a certified nurse anesthetist, to be present for every procedure, which then separates the gastroenterologist from having to focus on sedation. Right. Which makes the procedure as safe as possible. Most colonoscopies take, give or take, 15, maybe 20 minutes. So patients are under anesthesia for such a short period of time. And normally we can bridge the gap in terms of any other kind of ickiness or fear of the procedure once we discuss exactly what we've been discussing about how this is a purely preventative procedure. And if the patient goes through a colonoscopy and has no polyps, they wouldn't need to go through this again for another 10 years.
Yeah, we're going to go ahead, Dr. Martin.
Yeah, I would just add that from our standpoint, we also, we see and we understand that fear and that apprehension or the embarrassment, but we also see the flip side of the, 57-year-old who comes in finally convinced to do a colonoscopy, and they have a finding that's significant, and the sadness that comes with the diagnosis, but B, the idea that it could have been prevented if we had just done, the done thing.
Right. Yeah, delaying can be costly.
Yeah.
And you mentioned just the changes to the prep, going from 2 gallons to 1 liter over the course of, I suppose, a few hours, right?
An evening before.
An evening. I mean, that's significant. And I heard somebody telling me recently about you can kind of like mix it with like Gatorade or other things like that. Is that a new way to make it more palatable?
Yep.
There is a commonly used prep where you can mix Miralax with Gatorade that's been used for years.
Okay, there you go.
Yeah.
And you mentioned frequency of screening. Can you tell me, getting to the guidelines, what do the guidelines say specifically? And then after your first colonoscopy, what frequency should you then proceed with?
Start at 45, regardless of the modality, unless you have a family history, in which case you start 10 years earlier than the diagnosis of the first-degree relative. And then that would be, the follow-up would depend on what the findings are. So with a Cologuard, it would be every 3 years, assuming it's negative. If it's positive, you go to a colonoscopy directly at that moment. For colonoscopies, you would generally follow up depending on the number and size of polyps found on the baseline colonoscopy. So moving forward, it would be anywhere from, it could be a 3-year interval, a 5-year interval, a 7 or 10-year. It depends on the specific findings, but you get that kind of guidance at the end of your colonoscopy day. And as a matter of fact, you'll probably have a good sense for what the results are that day, because most biopsies that we do of polyps, you can pretty much tell whether or not they're concerning at all. So even though there's a biopsy out there that will be waiting for the results to come back, we can tell you that day right at the end of it if there's anything at all to be concerned about. I would mention also that the folks who say that, why do I need a colonoscopy? I don't have any family history. I would still say that while your risk, if you have a family history, does go up, we do find that still more than half of the people who get diagnosed with a colon cancer do not have the typical family history that warrants additional screening. So it certainly doesn't get you off the hook.
Yeah. Dr. Martin, you mentioned earlier that caught early, it's very treatable. So can you tell us a little bit about what people can expect?
Sure. So just like anything else, there's a very wide range. There's a large spectrum. Very superficial colon cancers that are within, say, the tip of a polyp occasionally can be removed endoscopically. So the same way that we remove a polyp, you can remove a very, very superficial cancer, but that is the vast minority of colon cancers. The majority of colon cancers are found much later in their course than that. Most colon cancers require surgery if there's no evidence of spread from the cancer beyond the colon, if that's feasible. If the cancer has spread beyond the colon to other organs or just outside of the colon to where surgery would not be an initial option, then most patients would need chemotherapy, and that would be through an oncologist. The details of that can become very nuanced depending on whether the cancer is within the rectum, whether it's higher up in the colon, where the cancer has spread to, and then specific pathology of the cancer. So specific markers that can be found when you look at the cancer under the microscope and stain for specific markers or targets, if you will. The real take-home point is that so many of the colon cancers are preventable. This is a very preventable disease. Many of these cancers can be avoided if we are doing appropriate screening and getting patients in a timely manner when they should be. Yeah.
And you mentioned sort of location of the cancer. Dr. Martin, just to follow up on that, I understand that like the lower the polyp and cancer is, the more difficult it can be to treat. I wonder if you could talk to that and what other people should know.
Yeah, certainly from a surgical approach, it can get a little bit more challenging to take out rectal cancers, especially when they're close to the anal canal. There is kind of a increasing body of literature that is supporting actually a certain subpopulation to just have radiation and chemotherapy without even a surgical intervention, and they're getting pretty good results, and I've seen a pretty incredible follow-up on that. Still, it is a discussion with the patient as to whether or not they go that route. Additionally, I would just say in terms of treatment in general, I think once someone gets a diagnosis, I would advise against kind of going out and Googling what survival rates are and stuff like that, because the data that was true 5-10 years ago just is not true now, and we do not have the same data and treatments that apply to that diagnosis today than even 5 years ago with immunotherapies and the like. So it's really it's made a lot of progress.
Yeah, you see miraculous stories, I think, across the spectrum in cancers, and the effect of immunotherapies you mentioned, targeted therapies, really seems to be a promising field that gets better and better by the year. At Northwell, we've launched an early-onset cancer program. Dr. Stein, I know that you're involved with this along with Dr. Shukla. I wonder if you could speak to that a little bit, and just the importance of support for these, younger adults, those under 50, in the various stages of life who are dealing with this in an increasing capacity.
Sure. So our initial goals with the early-onset colorectal cancer program are really to spread awareness and spread screening, appropriate screening. So that's really where we're beginning. We're partnering with both the oncology service line, the oncologists, and actually with local government. We were partnering with Shalita Ambler from the Department of Health in Westchester, really with the aim of dramatically increasing screening rates in the county. Interestingly, this has spread elsewhere in New York State to increase screening rates. So yes, we're trying to prevent earlier cancers. We're trying to raise awareness for what specific alarm signs and symptoms are, get patients in earlier when they should be screened. And that awareness needs to increase not only with patients, but actually with the providers, with primary care docs, and the first point of contact with the patients. So, yes.
Yeah, most definitely. And I think it's so important and great to hear about the collaboration between, Phelps Hospital, Northwell, and the county even. Dr. Martin, I wonder if you could talk about the services available at Phelps, and just what people should know, especially if they are, at that age where screening is recommended, and how they should proceed.
For starters, I would say just speak to your primary care doctor. They would definitely be able to refer you in the right direction. You can call the GI office directly. We are in the process of consolidating our medical gastroenterology services along with our surgical services into one digestive disease center, which will be up and probably breaking ground soon, but also up and running probably about a year and a half to 2 years, where we're just trying to streamline every possible GI issue and triage it appropriately so that we get very accessible care for any type of GI problem. But we also have kind of a direct access screening program wherein you can just see your primary care doctor and be triaged if there are no procedural risk factors directly to the procedure itself without even meeting the gastroenterologist first, unless you'd like to.
Wow.
Yeah.
Great expansion, important programmatic expansion to make sure that this is available and easy to navigate for the patients. Dr. Martin, Dr. Stein, thank you both again so much for joining me today and sharing valuable information for everybody about colorectal cancer screening. And to our viewers, if you'd like more information on colorectal cancer or screening guidelines or to book an appointment, please head to the link on your screen now. Thanks so much and have a great day.